Looks like I'm not looking as good as I usually do. I was up a little bit late last night. I had a hard time. Had a hard time falling asleep actually, because I was thinking about this talk, and I don't usually get real nervous for talks. I've done a few, and I don't get too nervous about giving talks, but I was nervous about this one, and I was especially nervous about the idea of conveying this concept that I want to talk about today, because I feel like it's so important, and it's something that I really want to do justice to by sharing this message well. So I was nervous about it, and I didn't sleep very well. I was going over in my mind what I was going to say, and the other thing that I was nervous about is because when I was asked to give this talk, the initial message of the talk was supposed to be how I built a successful DPC practice. And that idea was pretty daunting to me, because I don't think I'm going to be ready to give that talk for a few years. You know, when are you considered a success in your DPC practice? I'm not sure when I'm going to hit that point where I really feel like we've finished it. And that's part of what I want to talk about today, is what does DPC as a finished product look like? And so I will share a little bit of my story, of the story of starting this practice. And it's probably not too different than many of your stories. My story started when I was a little boy, and I was in a grocery store with my father, and I was holding my dad's hand, and a lady came up to us and said, "Did you know that your dad saved my son's life?" And I just thought, wow, this man, my dad, is a hero. He did something that that very few people could do for this family. He prevented so much suffering, and he reversed disease. And so from then on, that was going to be what I did with my life. I was going to be somebody who prevented disease and reversed suffering. And so I prepared for medical school. I got into medical school, and I'm sitting there in class, and I'm so excited to hear, how are we going to prevent disease and reverse suffering? And the lecture never came. You know, we talked about reducing risk of certain diseases. We talked about mitigating the effect of certain diseases. We learned all about how these diseases affect our bodies and some of the nasty things that happens to us when we get these diseases, but very little conversation about how to stop it from coming, how to prevent the pain from ever starting. We learned tons about all these medications that decrease the risk of a disease or decrease some of the effects of a disease. But how many of those medications actually reverse the disease? There's only a couple that I can think of, and I'd love to hear if you can think of more than me, but there's only a couple of medications that you could really think of being as miracle cures, or medications that change the course of the disease significantly. Now, wondering, is this not a thing? Is preventing disease, is reversing disease not a thing? And so I start doing my own research outside of what I hear in medical school, and it turns out it is a thing. You look on the Journal of the American Medical Association, New England Journal of Medicine, and all other places, and you can find plenty of evidence that says that most of the diseases that we suffer from in America are preventable. 80, 90% of it just doesn't have to happen. So then why am I a third-year medical student now, going into my first room with a patient who has sepsis from a diabetic wound? Why is the second patient somebody who has just had a stroke, a colon cancer? Why are all of these rooms that I'm going into, all these patients suffering from something that is supposed to be reversible? At least the data says it's reversible or preventable in the first place. Why is that? Why was this not happening? And I think the answer can be found once you start looking at where we spend money in medicine. And the money goes to about 5% goes to prevention of disease. And that prevention, that 5% that goes to prevention, really most of that's going into secondary prevention, colon cancer screening, breast cancer screening. And is that actually preventing disease? No, it's just catching it early and trying to decrease some of the effects of it. And so we're really not preventing, we're not even trying to prevent disease in medicine. It's not even something that we are doing. And so I'm thinking, well, okay, I guess that's not something that we're doing, but it's certainly something I'm going to do. You know, that's why I went into this in the first place, is so I could prevent disease and reverse disease. And so I decide as a resident that that's what I'm going to do. So I go into clinic, and you know, as a resident, I'm getting more patients each year in my own clinic, and I'm doing the stuff that the research says can prevent or reverse disease, or at least I'm talking about the things that the research says can prevent or reverse disease. And what's that? We know it's nutrition, it's exercise, it's sleep, it's emotional wellness, and avoiding things that hurt our bodies. So those things are already proven to help prevent and reverse disease. And so I'm just going to talk about them in clinic. I'm going to spend my time working on the thing that I know can prevent or reverse disease. And many of you may have had similar experiences. It turns out that doesn't fit very well in a 10-minute visit time. It wasn't part of the plan of the people that I was working for me to spend 40 minutes talking to a patient about their nutrition, about their exercise, about their sleep, and especially not about their depression, their anxiety. And so it wasn't fitting. And I was running an hour behind sometime. And at the end of the day, the medical assistants were doing paper, rock, scissors to see who had to stay with Dr. Kendrick this time. And then I was coming home to my family, and I was having a quick dinner, and then I was going into my office again and doing notes, and I was making phone calls from home. And this isn't what my life's about. You know, if you read my bio, you know that my life is about my family and about helping other people and about following Jesus Christ and doing the kind of work that he did. And I'm here spending way too much time with each patient in clinic, and finding I'm still not able to really affect many of the things that are most important to them because there's just not enough time to do it in clinic. I was desperate, honestly. I was maybe going to be leaving medicine because I didn't know how I was going to do the job that I came there to do. When I started to look around, I thought, well, first I thought, I'll just make less money. You know, I'll go into my own practice and I'll just make less money by seeing less patients, but doing better work for each patient. And so I even started doing some of the math behind that and found that math doesn't really work either in the old system. Why? Because 50 to 70% of your gross revenue in a primary care practice ends up going into overhead. And so if I want to decrease my patient load by 30%, that's not just going to decrease my income by 30%. It might decrease my income by 100% or maybe by 150%. Now I'm paying in order to stay in business. And I know people that are doing that because they are so passionate about what it means to do medicine. And that wasn't going to work. You know, I don't need a lot of money, but I need some money. I got $450,000 of student loans, and I've got 3 kids at the time, 4 kids now, and somebody's got to feed these kids. And so it just wasn't going to work for me to just cut back on patients in order to take care of people better. That's when direct primary care came into the story. This is probably a moment that you guys can remember too. First I heard direct primary care. I thought it was like a concierge medicine thing, and that sounded disgusting to me. I'm not going to just spend my life, trying to help rich people feel important at the doctor's office. But then when I actually found out what it was and realized that direct primary care is an opportunity for me to get paid for something other than just what the insurance companies want to pay me for. It's an opportunity for me to adjust and maybe set my own limits on how much time can be spent with a patient. I got out, I started a direct primary care practice with one of the greatest humans ever, Kirby Farnsworth, who started this practice with me, and we were doing the kind of work that we thought was most important. But I want to reflect back a little bit on what did we come for? What did we leave for? What was wrong with the old system? Was it just the fact that we didn't have enough time with the patient? Is that really the root cause? And at the end, I'd be happy to hear more ideas of what you think is the root cause. But for me, a light bulb went off one day when an executive came in to talk to us from the hospital company that owned my primary care clinic. And this executive comes in and he says, "Hey, you guys are doing a great job. Your clinic is breaking even, and all of our other clinics lose 10%. In fact, we plan on them losing 10%. And I was like, "What? You buy all these primary care clinics in town and plan on them losing 10%? So you're not profitable on any of these clinics?" And he's like, "Yeah, in fact, none of the primary care clinics owned by hospital companies are profitable. In fact, many lose a lot more than we do per each primary care clinic. So what are you in the business of? What is that primary care clinic there for?" Well, apparently you're not in the business of primary care. Where does the revenue come from? Well, of course we know where it comes from. It comes from people being sick in the hospital. So let me get this straight. I'm working for a company, and my job, as I understand it, is to prevent disease and keep people out of the hospitals. And the company owns my clinic in order to get my patients into their hospitals. Now, I'm not suggesting that this is a conspiracy. I'm not suggesting that these people are evil in any way. In fact, I know that they're just trying to do their best, at least many of them that I've talked to. But it's all backwards, right? It's all backwards that the company that I'm working for has the opposite of the best interest in mind for our patients, at least financially. Morally, they want to help people, but financially, how are they supposed to do that? So if I were to have a great idea, for example, I'm working for this hospital company and I have this great idea, and I go to the CEO and I say, "Hey, I figured out a way that we can keep our patients so healthy, I might be able to reduce our hospitalizations by 30%. And it's only going to take a little bit of money to do." What do you think the answer is going to be? It's not going to be, "Well, no, I'm evil and we don't want to help people." It's, "You know what, that's a great idea, but I just don't see, it doesn't look like we have room in the budget for that." And of course, there's no room in the budget for it. No business has room in their budget for ruining their business. There's not a budget line item that says this is the part of money that we spend on decreasing the need for our product in the first place. It's not how it works. So they're not evil people. It's not it's not a conspiracy. It's just a system with backwards incentives. And that's the part that I think that people, are just not real. that's the part that they don't want us talking about, right? That's the part they don't want us talking about, where this $3.5 trillion healthcare system is based on a system of backwards values. It's based on a system of backwards incentives. So $3.5 trillion that is up for grabs. Because just think about it. If you have all of this money that's going into paying for people to be sick, and now in the direct primary care movement, we figured out that you can actually get paid to help people be well, then all of that money is going to a legacy system, and it's just waiting for disruption. So in this setting where all of this money is up for grabs, just think about all of the time that you have that we are spending on sick care, when we just need to figure out how to get people well again. So that's my message for you, is that there is so much more innovation that is on the table, and direct primary care is not the destination, it's the launch pad. It's where we get to start innovating for the future of medicine. So I think I gotta go.